Today we will be discussing nutritional diseases. Millions of people in developing nations suffer or live on the cruel edge of starvation, whereas those in the developed world, and more recently in the developing world, struggle to avoid calories and the attendant obesity or fear that what they eat may contribute to atherosclerosis and hypertension. So both the lack of nutrition and overnutrition are major health concerns. Excess adiposity or obesity and excess body weight are associated with increased incidence of several of the most important diseases of humans, including type 2 diabetes, dyslipidemias, cardiovascular disease, hypertension, and cancer. It is a major public health problem in developed countries and an emerging health problem in developing nations such as India. In the United States, obesity has reached epidemic proportions. The prevalence of obesity increased from 13 to 34% between 1960 and 2008, and as of 2015, 68% of Americans between 20 and 75 years of age were overweight, as were 17% of the children. Globally, the World Health Organization estimates that in 2015, 700 million adults were obese. The causes of this epidemic are complex but undoubtedly are related to societal changes in diet and levels of physical activity. Obesity is defined as a state of increased body weight caused by adipose tissue accumulation that is of sufficient magnitude to produce adverse health effects. How does one measure fat accumulation? Several high-tech methods have been devised, but for practical purposes, the body mass index is most commonly used. Body mass index is calculated as weight in kilograms divided by height in meters, or kilograms over meters, square meters. The body mass index is closely correlated with body fat. Body mass index in the range of 18.5 to 25 are considered normal, whereas body mass index between 25 and 30 identified the overweight, and body mass index greater than 30 is considered obese. It is generally agreed that BMI greater than 30 imparts a health risk. In the following slides, for the sake of simplicity, the term obesity is applied to both the overweight and the truly obese. The untoward effects of obesity are related not only to the total body weight, but also to the distribution of the stored fat. Central or visceral obesity, in which fat accumulates in the trunk and in the abdominal cavity, in the mesentery and around viscera, is associated with a much higher risk of several diseases than is a condition of excess accumulation of fat in diffuse distribution in subcutaneous tissue. The etiology of obesity is complex and incompletely understood. Involved are genetic, environmental, and psychological factors. However, simply put, obesity is a disorder of energy balance. The two sides of the energy equation, intake and expenditure, are finely regulated by neural and hormonal mechanisms, so that body weight is maintained within a narrow range for many years. Apparently, this fine balance is controlled by an internal set point or lipostat that senses the quantity of energy stores adipose tissue and appropriately regulates food intake as well as energy expenditure. Several obesity genes have been identified. As might be expected, they encode the molecular components of the physiologic system that regulates energy balance. A key player in energy homeostasis is the LAP gene and its product leptin. This unique member of the cytokine family, secreted by adipocytes, regulates both sides of the energy equation, intake of food and expenditure of energy. As discussed later, the net effect of leptin is to reduce food intake and to enhance the expenditure of energy. In a simplified way, the neurohumoral mechanisms that regulate energy balance and body weight may be divided into three components: the peripheral or afferent system, the acute nucleus in the hypothalamus, and the afferent system. The peripheral or afferent system generates signals from various sites. Its main components are leptin and adiponectin, produced by fat cells, insulin from the pancreas, ghrelin from the stomach, and peptide YY from the ileum and colon. Leptin reduces food intake. Ghrelin secretion stimulates appetite, and it may function as a meal-initiating signal. Peptide YY, which is released postprandially by endocrine cells in the ileum and colon, is a satiety signal. The acute nucleus in the hypothalamus processes and integrates the peripheral signals and generates new signals that are transmitted by POMC, Pro or P melanocortin, and CART, cocaine and then amphetamine regulated transcript neurons, as well as NPY, neuropeptide Y, and AGRP, agouti-related peptide neurons. The afferent system, which consists of hypothalamic neurons regulated by the acute nucleus, is organized along two pathways, anabolic and catabolic, which control food intake and energy expenditure respectively. POMC, pro-opium melanocortin, and CART, cocaine and amphetamine regulated transcript neurons, activate afferent neurons that enhance energy expenditure and weight loss through the production of molecules such as alpha melanocyte stimulating hormone that reduce food intake. Alpha melanocyte stimulating hormone signals through melanocortin receptor. By contrast, neuropeptide Y and agouti-related peptide neurons activate afferent neurons that promote food intake and weight gain. Signals transmitted by different afferent neurons also communicate with forebrain and midbrain centers that control the autonomic nervous system. On the picture, you see reciprocal regulation of neuropeptide Y, agouti-related peptide neurons, and pro-opiomelanocortin neurons of the amphetamine-regulated transcript in the control of food intake. PVH on the picture means paraventricular nucleus of the hypothalamus, and ARC is the acute nucleus of the hypothalamus. Discussed next are two important components of the afferent system that regulate appetite and satiety: leptin and gut hormones, and adiponectin that regulates fat consumption. Leptin is secreted by fat cells, and its output is regulated by the adequacy of fat stores. Body mass index and body fat stores are directly related to leptin secretion. With abundant adipose tissue, leptin secretion is stimulated, and the hormone crosses the blood-brain barrier and travels to the hypothalamus, which it reduces food intake by stimulating pro-opiomelanocortin and cocaine and amphetamine regulated transcript neurons, and inhibiting neuropeptide Y and agouti-related peptide neurons. The opposite sequence of events occurs when there are inadequate stores of body fat. Leptin secretion is diminished and food intake is increased. In persons of stable weight, the activities of these pathways are balanced. Leptin also increases energy expenditure by stimulating physical activity, energy expenditure, and thermogenesis. And these may be the most important catabolic effects mediated by leptin through the hypothalamus. Although the effects of leptin on food intake and energy expenditure can be readily demonstrated in non-obese mice and humans, the anorexigenic response of leptin is blunted in states of obesity despite high levels of circulating leptin. Such leptin resistance in obese mice can be bypassed by intraventricular injection of leptin. In keeping with this observation, injection of leptin in obese humans failed to affect food intake and energy expenditure, dashing initial enthusiasm of leptin therapy for obesity. In rodents and humans, loss of function mutations affecting components of the leptin pathway give rise to massive obesity. Mice with mutations that disable the leptin gene or its receptor fail to sense the adequacy of fat stores, so they behave as if they are undernourished, eating ravenously. As shown on the picture, mice without the leptin gene are morbidly obese, is shown on the right, compared to normal mice shown on the left. As in mice, mutations of the leptin gene or receptor in humans, although rare, may cause massive obesity. More common are mutations in the melanocortin receptor 4 gene, MC4R, found in 4 to 5% of patients with massive obesity. As mentioned earlier, the melanocortin receptor 4 gene sends satiety signals by binding to this receptor. These monogenic traits underscore the importance of the leptin pathway in the control of body weight, and it is possible that more common types of defects in this pathway will be discovered in the obese. In closing, it should be mentioned that insulin also exerts anorexigenic responses. However, the mechanisms of these effects of insulin is less clear, and most of the evidence suggests the primacy of leptin in the regulation of adiposity. Adiponectin, produced in the adipose tissue, has been called a fat-burning molecule and the guardian angel against obesity. It directs fatty acids to muscle for their oxidation. It decreases the influx of fatty acids to the liver and the total hepatic triglyceride content. It also decreases glucose production in the liver, causing an increase in insulin sensitivity and protecting against the metabolic syndrome. In addition to its metabolic effects, adiponectin has anti-diabetic, anti-inflammatory, anti-atherogenic, anti-proliferative, and cardioprotective effects. Its serum levels are lower in obese than in lean individuals. These effects contribute to obesity-associated insulin resistance, type 2 diabetes, non-alcoholic fatty liver disease, and possibly increased risk of certain cancers. In addition to leptin and adiponectin, adipose tissue produces other mediators such as cytokines, chemokines, and steroid hormones, which allow adipose tissue to function as a link between lipid metabolism, nutrition, and inflammatory responses. The total number of adipocytes is established by the time of adolescence and is high in people who were obese as children, providing another reason for concern about childhood obesity. Although in adults approximately 10% of adipocytes turn over annually, the number of adipocytes remains constant regardless of individual body mass. Diets fail in part because the loss of fat from adipocytes causes leptin levels to fall, stimulating their appetite and diminishing energy expenditure. Gut hormones are rapidly acting initiators and terminators of volitional eating. Prototypical examples are ghrelin and peptide YY. Ghrelin is produced in the stomach and the arcuate nucleus of the hypothalamus. It increases food intake, acting most likely by stimulating the neuropeptide Y and agouti-related peptide neurons in the hypothalamus. Ghrelin levels probably rise before meals and fall 1 to 2 hours afterwards, but this drop is attenuated in obese persons. Ghrelin levels are lower in obese individuals as compared to those with normal weight, and they increase with reduction in obesity. Interestingly, the rise of ghrelin levels is much reduced in individuals in whom gastric bypass surgery is performed for the treatment of obesity, suggesting that beneficial effects of such surgery may be in part due to reduced surface of gastric mucosa that is exposed to food. Peptide Y is secreted from the endocrine cells in the ileum and colon in response to the consumption of food. It decreases appetite and augments a sense of fullness. It acts presumably by stimulating pro-opiomelanocortin and cocaine and amphetamine-regulated transcript neurons in the hypothalamus, thereby decreasing food intake. Peptide Y also reduces the rate of gastric emptying and intestinal motility, all of which contribute to satiety. Peptide Y levels are reduced with obesity and may be of therapeutic value in the treatment of those who are overweight or obese. An interesting series of observations suggests that the gut microbiome may be involved in the development of obesity. In support of this notion is the finding that the profiles of gut microbiota differ between genetically obese mice and the lean littermates. The microbiome of genetically obese mice can harvest much more energy from food as compared to that of lean mice. Colonization of the gut of germ-free mice by microbiota from obese mice is associated with increased body weight. The relevance of these models to human obesity is tantalizing, but remains to be proven. Obesity, particularly central obesity, is a known risk factor for a number of conditions, including type 2 diabetes, cardiovascular disease, and cancer. Central obesity also stands at the center of a cluster of alterations known as the metabolic syndrome, characterized by abnormalities of glucose and lipid metabolism coupled with hypertension and evidence of a systemic pro-inflammatory state. This seems to be caused by the inflammasome responses to free fatty acids and excess levels of lipids in cells and tissues. The inflammasome stimulates secretion of interleukin-1, which induces insulin resistance. Obesity is associated with insulin resistance and hyperinsulinemia, important features of type 2 diabetes. Excess insulin, in turn, may play a role in the retention of sodium, expansion of blood volume, production of excess norepinephrine, and smooth muscle proliferation that are the hallmarks of hypertension. Whatever the mechanism, the risk of developing hypertension among previously normotensive persons increases proportionally with weight. Obese persons generally have hypertriglyceridemia and low levels of high-density lipoprotein, factors that increase the risk of coronary artery disease. The association between obesity and heart disease is not straightforward. However, such linkage as there is relates more to the associated diabetes and hypertension than to weight per se. Non-alcoholic fatty liver disease is commonly associated with obesity and type 2 diabetes. It can progress to fibrosis and cirrhosis, as shown on the picture. Cholelithiasis or gallstones is 6 times more common in obese than in lean subjects. The mechanism is mainly an increase in total body cholesterol, increased cholesterol turnover, and augmented biliary excretion of cholesterol in the bile, which in turn predisposes affected persons to the formation of cholesterol-rich gallstones. Hypoventilation syndrome is a constellation of respiratory abnormalities in very obese persons. It has been called the Pickwickian syndrome after the fat lad who was constantly falling asleep in Charles Dickens' The Pickwick Papers. Hypersomnolence both at night and during the day is a characteristic and is often associated with apneic pauses during sleep, polycythemia, and eventual right-sided heart failure. Marked adiposity is a predisposing factor for the development of degenerative joint disease, osteoarthritis, This form of arthritis, which typically appears in older persons, is attributed in large part to the cumulative effects of wear and tear on joints. The greater the body burden of fat, the greater the trauma to joints with the passage of time. Markers of inflammation, such as C-reactive protein and pro-inflammatory cytokines like tumor necrosis factor, are often elevated in obese persons. The basis of the inflammation is uncertain. Both a direct pro-inflammatory effect of excess circulating lipids and increased release of cytokines from fat-laden adipocytes have been proposed. Whatever the cause, it is thought that chronic inflammation may contribute to many of the complications of obesity, including insulin resistance, metabolic abnormalities, thrombosis, cardiovascular disease, and cancer. There is an increased incidence of certain cancers in the overweight, including cancers of the esophagus, thyroid, colon, and kidney in men, and cancers of the esophagus, endometrium, gallbladder, and kidney in women. Overall, obesity is associated with approximately 20% of cancer deaths in women and 14% of deaths in men. The underlying mechanisms are unknown and are likely to be multiple. Elevated insulin levels are shown on the picture. Insulin resistance leads to hyperinsulinemia, which includes multiple effects that may directly or indirectly contribute to cancer. For example, hyperinsulinemia causes a rise in levels of free insulin-like growth factor 1. Insulin-like growth factor 1 is a mitogen, and its receptor, insulin-like growth factor receptor, is highly expressed in many human cancers. Insulin-like growth factor receptor 1 activates the reticular activating system and intracellular signal transduction pathways, which promote the growth of both normal and neoplastic cells. Obesity has effects on steroid hormones that regulate cell growth and differentiation in the breast, uterus, and other tissues. Specifically, obesity increases the synthesis of estrogen from androgen precursors, increases androgen synthesis in ovaries and adrenals, and enhances estrogen availability in obese persons by inhibiting the production of sex hormone binding globulin in the liver. As discussed earlier, adiponectin secretion from adipose tissue is reduced in obese individuals. Adiponectin suppresses cell proliferation and promotes apoptosis. It also counteracts the actions of p53 and p21. In obese individuals, these anti-neoplastic actions of adiponectin may be compromised. The pro-inflammatory state that is associated with obesity may itself be carcinogenic. In a summary, we can say that obesity is a disorder of energy regulation. It increases the risk for a number of important conditions such as insulin resistance, type 2 diabetes, hypertension, and hypertriglyceridemia, which are associated with the development of coronary artery disease. The regulation of energy balance is very complex. It has three main components: different signals provided mostly by insulin, leptin, ghrelin, and peptide Y, the central hypothalamic system, which integrates afferent signals and triggers the efferent signals, and efferent signals, which control energy balance. Leptin plays a key role in energy balance. Its output from adipose tissue is regulated by the abundance of fat stores. Leptin binding to its receptors in the hypothalamus reduces food intake by stimulating POMC-CR neurons and inhibiting NPY-AGRP neurons. In addition to diabetes and cardiovascular disease, obesity also is associated with increased risk for certain cancers, non-alcoholic fatty liver disease, and gallstones. A healthy diet provides sufficient energy in the form of carbohydrates, fats, and proteins for the body's daily metabolic needs. Essential amino acids and fatty acids used as building blocks for synthesis of structural and functional proteins and lipids, and vitamins and minerals which function as coenzymes or hormones in vital metabolic pathways, or as in the case of calcium and phosphate as important structural components. In primary malnutrition, one or all of these components are missing from the diet. By contrast, in secondary or conditional malnutrition, the dietary intake of nutrients is adequate. The malnutrition results from nutrient malabsorption, impaired use of storage, excess losses, or increased requirements. The causes of secondary malnutrition can be grouped into three general but overlapping categories: gastrointestinal diseases, chronic wasting diseases, and acute critical illnesses. Malnutrition is widespread and may be gross or subtle. Some common causes of dietary insufficiencies will be discussed now. Homeless people, elderly persons, and children of the poor often suffer from severe malnutrition as well as trace nutrients deficiencies. In poor countries, poverty, together with droughts, crop failure, and livestock deaths, creates the setting for malnourishment of children and adults. Even the affluent may fail to recognize that infants, adolescents, and pregnant women have increased nutritional needs. Ignorance about the nutritional content of various foods also contributes to malnutrition as follows. Iron deficiency often develops in infants exclusively fed artificial milk diets. Polished rice, used as the mainstay of the diet, may lack adequate amounts of thiamine. The iodine often is lacking in food and water in regions removed from the oceans unless supplementation is provided. Alcoholic persons may sometimes suffer from malnutrition but are more frequently lacking in several vitamins, especially thiamine, pyridoxine, folate, and vitamin A as a result of dietary deficiency, defective gastrointestinal absorption, abnormal nutrient utilization and storage, increased metabolic needs, and an increased rate of loss. A failure to recognize thiamine deficiency in patients with chronic alcoholism may result in irreversible brain damage, including Korsakoff psychosis. The basal metabolic rate becomes accelerated in many illnesses, especially in patients with extensive burns. It may double. That results in increased daily requirement for all nutrients. Failure to recognize these nutritional needs may delay recovery. Malnutrition is often present in patients with advanced cancer and AIDS. Anorexia nervosa, bulimia, and less overt eating disorders affect a large population of persons who are concerned about body image or suffer from an unreasonable fear of cardiovascular disease. Additional causes of malnutrition include gastrointestinal diseases, acquired and inherited malabsorption syndromes, specific drug therapies which block uptake or use of particular nutrients, and total parenteral nutrition. The World Health Organization defines severe acute malnutrition as a state characterized by a greatly reduced weight-height ratio that is below 3 standard deviations of WHO standards. Worldwide, about 16 million children under the age of 5 years are affected by it. It is common in poor countries, where as many as 25% of children may be affected and where it is a major contributor to the high death rates among the very young. In addition to loss of life, wars also exact a heavy toll on refugees who live in abject poverty. In camps set up for refugees from Syria, as many as 20% of children are severely or moderately malnourished. Severe acute malnutrition, previously called protein energy malnutrition, manifests as a range of clinical syndromes, all resulting from a dietary intake of protein and calories that is inadequate to meet the body's needs. The two ends of the spectrum of severe acute malnutrition are known as marasmus and kwashiorkor. It should be noted that from a functional standpoint, there are two protein compartments in the body. The somatic compartment, represented by proteins in skeletal muscles, and the visceral compartment, represented by protein stores in the visceral organs, primarily the liver. These two compartments are regulated differently, as detailed subsequently. The somatic compartment is affected more severely in marasmus, and the visceral compartment is depleted more severely in kwashiorkor. The diagnosis of severe acute malnutrition is obvious in its most severe forms. In mild to moderate forms, the usual approach is to compare the body weight for a given height against standard tables. Other helpful parameters are fat stores, muscle mass, and levels of certain serum proteins. With loss of fat, measured skin fold thickness, which includes skin and subcutaneous tissue that is reduced, if the somatic protein compartment is catabolized, the resultant reduction in muscle mass is reflected by reduced circumference of the midarm. Measurement of serum proteins, albumin, transferrin, and others provides an estimate of the adequacy of the visceral protein compartment. Recent studies suggest a role for the gut microbiome in the pathogenesis of severe acute malnutrition. There is a substantial difference in the microbial flora of children with severe acute malnutrition when compared with the gut microbiome of normal children. It seems that the alterations in the microbiome are not merely the consequences of severe acute malnutrition, but play a role in their causation. Marasmus developed when the diet is severely lacking in calories. A marasmic child suffers growth retardation and loss of muscle mass as a result of catabolism and depletion of the somatic protein compartment. This seemed to be an adaptive response that provides the body with amino acids as a source of energy. Of interest, the visceral protein compartment, which presumably is more critical for survival, is depleted only marginally, so serum albumin levels are either normal or only slightly reduced. In addition to muscle proteins, subcutaneous fat is also mobilized and used as fuel. Leptin production is low, which may stimulate the hypothalamic pituitary adrenal axis to produce the high levels of cortisol and contribute to lipolysis. With such losses of muscle and subcutaneous fat, the extremities are emaciated. By comparison, the head appears too large for the body. Anemia and manifestations of multivitamin deficiencies are present, and there is evidence of immune deficiency, particularly of T-cell mediated immunity. Hence, concurrent infections are usually present, which impose an additional stress on an already weakened body. Kwashiorkor occurs when protein deprivation is relatively greater than the reduction in total calories. This is the most common form of severe acute malnutrition seen in African children who have been weaned too early and subsequently fed almost exclusively a carbohydrate diet. The name kwashiorkor, which is the Ga language in Ghana, describes the illness in a baby that appears after the arrival of another child. The prevalence of this condition also is high in impoverished countries of Southeast Asia. Less severe forms may occur worldwide in persons with chronic diarrheal states in which protein is not absorbed, or in those with chronic protein losing enteropathies, the nephrotic syndrome, or the aftermath of extensive burns. Rare cases of this condition resulting from fad diets or replacement of milk by rice-based beverages have been reported in the United States. In kwashiorkor, unlike in marasmus, marked protein deprivation is associated with severe loss of the visceral protein department, and the resultant hypoalbuminemia gives rise to generalized or dependent edema. The weight of children with severe condition typically is 60 to 80% of normal. However, the true loss of weight is masked by the increased fluid retention. In further contrast with marasmus, there is a relative sparing of subcutaneous fat and muscle mass. The modest loss of the compartments may also be masked by edema. Children with kwashiorkor have characteristic skin lesions with alternating zones of hyperpigmentation, desquamation, and hyperpigmentation, giving a flaky paint appearance. Hair changes include loss of color or alternating bands of pale and darker color, straightening, fine texture, and loss of firm attachment to the scalp. Other features that distinguish this condition from marasmus include an enlarged fatty liver, resulting from the reduced synthesis of the carrier protein component of lipoproteins, as well as the development of apathy, listlessness, and loss of appetite. As in marasmus, vitamin deficiencies are likely to be present, as are defects in immunity and secondary infections. In kwashiorkor, the inflammation caused by infection produces a catabolic state that aggravates the malnutrition. As already mentioned, marasmus and kwashiorkor represent the two ends of spectrum, and considerable overlap exists. In the United States, secondary malnutrition often develops in chronically ill older and bedridden patients. It is estimated that more than 50% of older residents in nursing homes in the United States are malnourished. Weight loss of more than 5% resulting from malnutrition increases the risk of mortality in nursing home patients by almost fivefold. A particularly severe form of secondary malnutrition called cachexia often develops in patients with advanced cancer. The wasting is all too apparent and often presages death. Although loss of appetite may partially explain it, cachexia may appear before the appetite decreases. The underlying mechanisms are complex but appear to involve cytokines secreted by tumor cells, particularly tumor necrosis factor, which are released as part of the host response to advanced tumors. These factors directly stimulate the degradation of skeletal muscle proteins and also stimulate fat mobilization from lipid stores. The hallmark anatomic changes in severe acute malnutrition are growth failure, peripheral edema in kwashiorkor, and loss of body fat and atrophy of muscle, more marked in marasmus. The liver in kwashiorkor, but not in marasmus, is enlarged and fatty. Superimposed cirrhosis is rare. In kwashiorkor, rarely in marasmus, the small bowel shows a decrease in the mitotic index in the crypts of the glands associated with mucosal atrophy, loss of villi and microvilli. In such cases, concurrent loss of small intestinal enzymes occurs, most often manifested as desaccharidase deficiency. Hence, infants with kwashiorkor are lactate intolerant initially and may not respond well to full-strength milk-based diets. With treatment, the mucosal changes are reversible. The bone marrow in both kwashiorkor and marasmus may be hypoplastic, mainly as a result of decreased numbers of red cell precursors. Therefore, anemia is usually present, most often hyperchromic, microcytic due to iron deficiency, but the concurrent deficiency of folate may lead to a mixed microcytic-macrocytic anemia. The brain in infants who are born to malnourished mothers and who suffer from severe malnutrition during the first 1 or 2 years of life has been reported by some investigators to show cerebral atrophy or shrinkage, a reduced number of neurons, and impaired myelination of white matter. Many other changes may be present, including thymic and lymphoid atrophy, anatomic alterations induced by intercurrent infections, particularly with endemic helminths and other parasites, and deficiencies of the required nutrients such as iodine and vitamins. Anorexia nervosa is a state of self-induced starvation resulting in marked weight loss. Bulimia is a condition in which the patient binges on food and then induces vomiting. Bulimia is more common than anorexia nervosa and carries a better prognosis. It is estimated to occur in 1 to 2% of women and 0.0% of men with an average age at onset of 20 years. These disorders occur primarily in previously healthy young women who have acquired an obsession with attaining or maintaining thinness. The clinical findings in anorexia nervosa generally are similar to those in severe acute malnutrition. In addition, effects of the endocrine system are prominent. Amenorrhea resulting from decreased secretion of gonadotropin-releasing hormone and consequent decreased secretion of luteinizing and follicle-stimulating hormones is so common that its presence is almost a diagnostic feature. Other common findings related to decreased thyroid hormone release include cold intolerance, bradycardia, constipation, and changes in the skin and hair. In addition, dehydration and electrolyte abnormalities are frequent findings. Body hair may be increased but usually is fine and pale. Bone density is decreased, most likely because of low estrogen level, which mimics the postmenopausal acceleration of osteoporosis. As expected with severe malnutrition, anemia and lymphopenia, and hypoalbuminemia may be present. A major complication of anorexia nervosa is an increased susceptibility to cardiac arrhythmia and sudden death, both resulting from hypokalemia. In bulimia, binge eating is the norm. Huge amounts of food, principally carbohydrates, are ingested only to be followed by induced vomiting. Although menstrual irregularities are common, anorexia occurs in less than 50% of bulimic patients, probably because weight and gonadotropin levels are maintained near normal. The major medical complications are related to continual induced vomiting and chronic use of laxatives and diuretics. These include electrolyte imbalances, which predispose the patient to cardiac arrhythmias, pulmonary aspiration of gastric contents, and esophageal and stomach rupture. Nevertheless, there are no specific signs and symptoms for this syndrome, and the diagnosis must rely on a comprehensive psychological assessment of the patient. Primary severe acute malnutrition is a common cause of childhood deaths in poor countries. The two main primary severe acute malnutrition syndromes are marasmus and kwashiorkor. Secondary severe acute malnutrition occurs in the chronically ill and in patients with advanced cancer. Kwashiorkor is characterized by hypoalbuminemia, generalized edema, fatty liver, skin changes, and defects in immunity. It is caused by a diet low in protein but normal in calories. Marasmus is characterized by emaciation resulting from loss of muscle mass and fat with relative preservation of serum albumin. It is caused by a diet severely lacking in calories, both protein and non-protein. Anorexia nervosa is self-induced starvation. It is characterized by amenorrhea and multiple manifestations of low thyroid hormone levels. Bulimia is a condition in which food binges alternate with induced vomiting. The problems of under- and overnutrition as well as specific nutrient deficiencies have been discussed. However, the composition of the diet, even in the absence of any of these problems, may make a significant contribution to the causation and progression of the number of diseases. A few examples surface here. Currently, one of the most important and even controversial issues is the contribution of diet to atherogenesis. The central question is whether dietary modification, specifically reduction in the consumption of foods high in cholesterol and saturated animal fats, can reduce serum cholesterol levels and prevent or retard the development of atherosclerosis in those with no previous episode of cardiovascular disease. This is called primary prevention. We know some but not all the answers. The average adult in the United States consumes a large amount of fat and cholesterol daily, with a ratio of saturated fatty acids to polyunsaturated fatty acids of about 3:1. Lowering the levels of saturates to the level of polyunsaturates causes a 10% to 15% reduction in serum cholesterol within a few weeks. Vegetable oils and fish oils contain polyunsaturated fatty acids and are good sources of such cholesterol-lowering lipids. Fish oil fatty acids belonging to the omega-3 or N3 family have more double bonds than do the omega-6 or N6 fatty acids found in vegetable oils. A corollary of this idea is that supplementation of diet with fish oils might protect against atherosclerosis. One study of Dutchmen whose usual daily diet contained 30 grams of fish showed a substantially lower frequency of death from coronary heart disease than that among comparable control subjects. However, other studies have shown that omega-3 fatty acid supplements do not reduce the risk of cardiovascular diseases, suggesting that yet unknown components of fish may be required for cardioprotection. Other specific effects of diet on disease have been recognized. Restricting sodium intake reduces hypertension. Dietary fiber or roughage resulting in increased fecal bulk is thought by some investigators to provide a preventive effect against diverticulosis of the colon. Caloric restriction has been convincingly demonstrated to increase lifespan in experimental animals, including monkeys. The basis for this striking observation is not clear, though. Even lowly garlic has been touted to protect against heart disease, although research has yet to prove these effects unequivocally. With respect to carcinogenesis, three aspects of the diet are of concern: the content of exogenous carcinogens, the endogenous synthesis of carcinogens from dietary components, and the lack of protective factors. An example of an exogenous carcinogen is aflatoxin, which is an important factor in the development of hepatocellular carcinomas in parts of Asia and Africa. Exposure of aflatoxin causes a specific mutation in the TP53 gene in tumor cells. The mutation can be used as a molecular signature for aflatoxin exposure in epidemiologic studies. The concern about endogenous synthesis of carcinogens or promoters from components of the diet relates principally to gastric carcinomas. Nitrosamines and nitrosamides are suspected to generate these tumors in humans as they induce gastric cancers in animals. These compounds are formed in the body from the nitrites and amines or amides derived from digested proteins. Sources of nitrites include sodium nitrite added to foods as preservative and nitrites presented in common vegetables, which are reduced in the gut by bacterial flora. There is then the potential for endogenous production of carcinogenic agents from dietary components, which might well have an effect on the stomach. High animal fat intake combined with low fiber intake has been implicated in the causation of colon cancer. The most convincing explanation for this association is as follows. High fat intake increases the level of bile acids in the gut, which in return modifies intestinal flora, flavoring the growth of microaerophilic bacteria. The bile acids or bile acid metabolites produced by these bacteria might serve as carcinogens or promoters. The protective effect of a high fiber diet might relate to increased stool bulk and decreased transit time, which decreases the exposure of mucosa to putative offenders, and the capacity of certain fibers to bind carcinogens and thereby protects the mucosa. Attempts to document these theories in clinical and experimental studies have on the whole led to the contradictory results. Vitamin C and E, beta-carotenes, and selenium have been assumed to have anti-carcinogenic effects because of their antioxidant properties. To date, however, no convincing evidence has emerged to show that these antioxidants act as chemopreventive agents. As already mentioned, retinoic acid promotes epithelial differentiation and is believed to reverse squamous metaplasia. Therefore, despite many tantalizing trends and proclamations by diet gurus, to date there is no definitive proof that diet in general can cause or protect against cancer. Nonetheless, concern persists that carcinogens lurk in things as pleasurable as juicy steak and rich ice cream. Thank you for your attention.